All right. So some of you who have been following me, like Dr. White, you probably have seen one or two cases. But I promise you, I'll show you more new cases. So let's start with some cases, and we're gonna do it. So these are some of the important safety information related to the product. So we're gonna do it the same way we added these in the nuclear lab when these cases were acquired and we did the acquisition. So obviously the first case is gonna be a normal one. So 58-year-old lady, history of hypertension, hypercholesterolemia. We stressed her with regadenoson. Her heart rate went up from 81 to 111. So this is something that we take into account because this is something very important to have an increase in the heart rate. So that's good. With regadenoson, we like to see 20-25% increase. The blood pressure dropped a little bit, which is expected also with vasodilator stress. Her EKG is normal and calcium score is normal. Sorry, not normal, at 35, mildly increased. All right, so these are the flurpiridaz images. Anyone sees anything? So the only thing I would like to point out, I mean, obviously image quality is enhanced with an F18 tracer because of the characteristics of the F18. The main thing you want to look at is always look at the apex. If you see also on the upper short axis, apical thinning is part of the game here. And this is not because of something pathologic. The apex itself is thin. So we see it more pronounced here. And you can see here it's a normal without any perfusion defect. All right, these are the gated images. And it kind of confirmed that this is apical thinning. So if you keep your eye at the apex, you can see that there is no regional wall motion abnormality that you see here in terms, especially at the apex, there is normal contractility. And the ejection fraction went up 3%. So that's good. And this is the flow data that we got in this patient. And this is, I'm showing you the map. So you can see the rest flow is normal, the hyperemic flow is normal, the flow reserve is normal. So this is hopefully a low risk patient with mild atherosclerosis that will require management, obviously, but there is no evidence of obstructive coronary disease in this patient. Any question about this before we move on? All right, let's move on to the second patient. This is an 80-year-old female. She has a history of heart failure, cardiomyopathy, hypertension, diabetes, dyslipidemia, former smoker. You can see when we gave regadenoson, her heart rate went up from 79 to 90. The blood pressure dropped, which is expected. And the EKG changes were non-diagnostic because there were some resting changes there. Now, what do you see here? Normal, abnormal? Dr. White, you know this case. The second one you don't know. Okay. So abnormal. So we talked about the apical thinning, but now you can see that there is a defect. Now it's reversible. So it's more than what we call apical thinning. So this is something that we want to recognize apical thinning, but at the same time, we want to be sure that not to overlook defects in these patients who have apical thinning, who has apical ischemia in there. And now looking at the gated information, you can see the EF still went up because the area under jeopardy for the myocardium is decreased. And now this is the map of flow when we looked at this. So you can see that this patient resting flow is normal, but the hyperemic flow is also normal. The global flow is normal. But when I look at the regional, now I see that there is an area that has the area of perfusion defect has reduced myocardial blood flow. So this is something to keep in mind. It's the same area that correlate with what we see in this patient who has a perfusion defect. Clearly, there is an ischemic perfusion defect. It's a smaller one, limited to the distal LED and apex. She still went to the cath lab. The calcium score I didn't show you, it's 1900. So they were concerned whether we might be underestimating disease, although the flow is reassuring in terms of the RCA, although there is high calcium, and the other that the flow limitation is probably more limited to the area of perfusion defect. And she did go to the cath lab, and she has normal right system, but the LAD itself has a distal lesion which was labeled as 80% and which was stented there. So you can see the stent there, and the prior one showed it there. So unfortunately, I can't. Let me see if I go back, if it runs again. Yeah, so you can see the LAD lesion very distally, and it was stented there. Any questions? So it's a distal LAD lesion that required and that was responsible for this ischemic defect. Any question? All right. So we have 76-year-old male, hypertension, hypercholesterolemia, prior heart failure, myocardial infarction. We know that the patient has a prior stent in the left circumflex. We gave regadenoson, the heart rate went up a little bit, the blood pressure almost didn't change, EKG is normal. And so what do we see here? Do you want to say it, Dr. White? I don't know. I know, I've known Dr. White for a long time, so.
Lateral wall.
Lateral wall, fixed, reversible.
Looks mildly reversible.
So minimally reversible, totally agree with. So that there is a large perfusion defect in the entire lateral wall, mostly basal and mid, and looks significantly fixed with minimal reversibility. So infarct with peri-infarct ischemia. These are the gated images. So akinesis to hypokinesis in this area of the perfusion defect. And now we're looking at the flow data. So this is a patient with heart failure cardiomyopathy. You can see that the rest flow is to start with reduce, but the peak flow obviously is lower in the area of this that the patient has perfusion defect. And when we're looking at this, there is a prior myocardial infarction and there is a plaque in there, ulcerated plaque in this area. And the right has a distal lesion in it too, the PDA. So kind of confirmed that this patient had an infarction primarily related to this hazy lesion that you had in the circumflex. All right, 67-year-old female, hypertension, hypercholesterolemia, diabetes, heart rate with regadenoson went up significantly, blood pressure came down, and SC depression in the inferior and lateral leads. Normal or abnormal? Abnormal? Which vessel? LAD? What about the circ and the RCA? Shall we call it normal? So the area is perfused, but remember now you're looking at relative perfusion. So with relative perfusion, they look okay, but if there is disease in there, you're saying the worst segment. So I'm still not sure based on this, just relative perfusion, whether I'm dealing with single vessel or multi-vessel disease, and then I have to gather more information. So now looking at gated images, there is 10% drop in ejection fraction, but the ischemic perfusion defect was also big. There was significant TID there. So, but it is expected with this large perfusion defect that you see. Now the flows. Let's try to dissect the numbers. So clearly we know that this is 1.29, this is reduced flow. And the resting flow is kind of okay in most of them. But now when I'm looking at the stress flow of the LED, it's kind of like still phenomena there. So we really induced ischemia in this case. So the flow went down in the LAD. While in the circumflex and RCA, they are okay, but they are mostly because there is the perfusion defect. So they appear to be a little bit down in there. So it's a large perfusion defect, big LAD, and usually when we have still phenomena, it's concerning for um, chronic total occlusions without collaterals. So this is where you technically induce ischemia per se, and this is exactly what this patient had. So the patient had significant chronic total occlusion. Last case I'll show you before we turn it over to the second group. 76-year-old male, hypertension, hypercholesterolemia, CKD, prior amide, smoker. We gave regadenoson, heart rate as expected went up 27 beats. Blood pressure dropped, actually went up a little bit. And there are non-diagnostic EKG because of resting changes. Now, what do we see? So inferolateral ischemia. So actually, it's more than just inferolateral. Inferior, inferolateral, inferoseptal, RV uptake. What else you want? TID. So there is also some aspect of it that's relatively fixed there. So you see some fixed element there. Although I have to say, yeah, and also it's in the apical too. But in the basal, there is an element of fix which probably correspond to like the area that is. Sometimes we see that in like chronic lesions and ischemic lesions, but sometimes you can see it also in severely ischemic lesions. All right, what do you want to imagine here? Inferior wall, akinetic, hypokinetic, what's happening? This one moves on its own quickly. It's giving you the answer. All right, single vessel or multi-vessel disease? Super dominant, right? Single vessel, LAD involved or not involved? So when I tease out, when I look at these numbers, obviously large ischemic burden, a lot of patients have ischemia there. So I'm pretty confident that this is a lot of myocardium at jeopardy. So this patient, I will be hesitant to treat them just medically. But when we start to tease out the regional flows, you can see that the resting flows are normal. The LAD improved to almost 2.5. The RCA, the RCA totally it improved. But if you look even in the inferior area where we saw a lot of ischemia, that area, the flow reserve in red is 1.4. So this is in comparison to the prior case where we had a CTO. This one, either if it is a CTO, there will be good collateral supplying it, and that's why the flow still increased in the ischemic territory. And the calcium score is pretty elevated even in the left main and the LAD, but the RCA is not very high. And when we look here, you can see it is an RCA CTO, but there were good collaterals from the right. So that's why we didn't have the seed phenomena that we saw in the prior case where there was significant disease in here. And a big shout out to our technologists who are acquired these cases here standing there next to you. All right.